Hello colleagues, I'm Subodh Verma here at the American College of Cardiology 2019 Scientific Sessions, where I've just presented a paper entitled The Impact of Microvascular Disease on Cardiorenal Outcomes in the LEADER and SUSTAIN 6 trials, and I'm pleased to share some of the key learnings from those analyses with you today. Shown in this slide are my financial disclosures. So as many of you are aware, LEADER and SUSTAIN 6 are two cardiovascular outcome trials in people with type 2 diabetes. The first trial enrolled 9,340 patients. The second trial enrolled 3,297 patients. They all had type 2 diabetes and either had established cardiovascular disease or had multiple cardiovascular risk factors. And these patients were randomized to receive liraglutide or semaglutide, either given once daily or once weekly, respectively, in the two trials. And the primary outcome of these trials were major adverse cardiovascular events. There were important secondary outcomes that included the expanded the expanded MACE outcome, as well as renal outcomes. As the audience appreciates, microvascular disease is known to be an important risk stratifier, and we know that it can be associated with increased risk of cardiovascular events. However, we don't know much about the role of microvascular disease as a risk stratifier in the context of contemporary cardiovascular outcome trials, particularly in the context of patients who have been well treated, and furthermore, the interface or interplay between microvascular disease in patients with coexisting macrovascular disease as it relates to vascular risk has not yet been evaluated. So let me tell you a bit about the population as it relates to the history of microvascular disease. On your left are data from the LEADER trial, and in the Venn diagram you see the proportion of patients who had investigator-reported history of nephropathy, retinopathy, or neuropathy. And as you can see again, 17% of patients in LEADER had a history of nephropathy, 4% had a history of retinopathy, and 12% had a history of neuropathy. Approximately 4 to 10% of patients in LEADER had 2 microvascular complications, and 6% had all 3. And the distribution was relatively similar in the SUSTAIN 6 trial as well. Shown in this slide are the baseline characteristics by history of microvascular disease or not. On your left, two columns are the LEADER data, and on your right are SUSTAIN 6. And as you would anticipate, patients who had type 2 diabetes and greater than or equal to 1 microvascular complication tended to have a longer duration of type 2 diabetes, approximately 4 years longer than patients who did not have a history of microvascular disease. Insulin use tended to be about 15% higher in patients with a history of microvascular disease. There was a slightly higher blood pressure noted in this population, and again, as expected, there was more renal disease, and shown here is the GFR, a lower eGFR in patients with a history of microvascular disease compared to those who did not have microvascular disease. Let us look at the overall cardiovascular event rate by the presence of microvascular disease at baseline. And what you see here in the LEADER trial on the left and SUSTAIN 6 on the right, that as you go from the light blue to dark blue to then gray line, there is a graded increase in risk of major adverse cardiovascular events by a history of microvascular disease, such that those who have no microvascular disease compared to people who have 1 or more seem to have a greater increase in overall major adverse cardiovascular events. We then evaluated the efficacy of liraglutide and semaglutide for the outcome of major adverse cardiovascular events that is shown in this slide. To remind our viewers, in the overall total population from LEADER, the hazard ratio was 0.87, consistent with a 13% relative risk reduction in the overall LEADER population. And across the various subgroups, people with retinopathy, neuropathy, nephropathy, or those who had no microvascular complication, one or more than one, no matter how you evaluate the entire cohort, there was a consistent benefit of liraglutide to reduce major adverse cardiovascular events with no statistical heterogeneity. The expanded MACE included the triple MACE outcome plus hospitalizations for unstable angina, coronary revascularization, or heart failure. And what you see here again is consistent benefits across the various strata. And then finally, the nephropathy outcome as well, demonstrating consistency in people with and without the presence of microvascular disease or any specific component of microvascular disease as listed here. We then looked at the renal outcomes and cardiac outcomes, this SUSTAIN-6, and the story is very similar. The sample size is smaller and therefore the confidence intervals are wide, but you can see here really no statistical heterogeneity for MACE, expanded MACE, or nephropathy in the trial based on the presence or absence of microvascular disease or not. Finally, we tried to appreciate the interface in patients who have concomitant micro and macrovascular disease. And in the LEADER trial and in SUSTAIN-6, we noted that approximately 40% and 50% respectively of individuals had both micro and macrovascular disease. And we wanted to understand, A, what the risk level of these patients are and whether they derived a similar, greater or lesser benefit with these GLP-1 receptor agonists or analogs. And what you can see in this slide here is for the MACE outcome in the placebo group, this actually demonstrates that the highest placebo event rate was observed in patients with type 2 diabetes who had both micro and macrovascular disease. And there was a very consistent benefit with liraglutide and semaglutide observed in the entire population and of course in people with micro, macro, or the combination. That held true for the expanded MACE. It also held true for the nephropathy composite that is mentioned here. Similar data have been seen with semaglutide in the SUSTAIN-6 trial. So how do we put this all together? This is a post-hoc analysis from LEADER and SUSTAIN-6. We have looked at the overall cardiovascular and renal risk in patients who have microvascular disease, either one or more. We've looked at the individual components of microvascular risk and essentially demonstrate that microvascular risk is an important risk stratifier for cardiovascular events. It stratifies risk in people with diabetes, with or without established macrovascular disease, and that these two GLP-1 RAs have consistent benefit in both of the trials across the spectrum of patients with microvascular disease. I hope you found this valuable and that some pearls here may be useful in your clinical practice.